If you're approaching Medicare, you've probably heard the terms Part A and Part B over and over again. But here's the question that really matters. When you actually need health care, what does Medicare pay for? And what could still come out of your pocket? That's what we're going to answer in this video. Medicare Part A and Part B together are often called Original Medicare. Part A is primarily your hospital coverage. It can help pay for inpatient hospital care, certain skilled nursing facility care, hospice care, and some home health services. Part B is your medical coverage. It helps pay for things like doctor visits, outpatient care, preventive services, medical equipment, and many other medically necessary services. That sounds fairly comprehensive. But there's an important point that every retiree should understand. Original Medicare does not mean that all of your healthcare costs are covered. There are premiums, deductibles, coinsurance, and other expenses you may have to pay yourself. And unlike many employer health plans, Original Medicare does not have an annual limit on how much you could potentially pay out of pocket for covered Part A and Part B services. There are also important things Original Medicare generally doesn't cover. That distinction can have a significant impact on your retirement budget. So, we're going to take Part A and Part B separately. We'll look at what each part covers, what you may have to pay, and then put the pieces together with practical examples. By the end, you should have a much clearer picture of what having Original Medicare actually means for your healthcare costs in retirement. Let's begin with Medicare Part A, the part most people associate with hospital coverage. Medicare Part A is commonly called hospital insurance. But understanding Part A requires more than simply knowing that Medicare pays for a hospital stay. You need to understand what qualifies as inpatient care, how the deductible works, and something called a benefit period. Because that's where Medicare Part A can become confusing. Let's start with coverage. Part A generally helps cover inpatient hospital care, skilled nursing facility care under certain conditions, hospice care, and some home health care. For most Medicare beneficiaries, Part A has no monthly premium. That's because you or your spouse generally paid Medicare taxes for at least 10 years while working. If you don't qualify for premium-free Part A, you may be able to purchase it. In 2026, the monthly premium is either $311 or $565, depending on how long you or your spouse paid Medicare taxes. But premium-free does not mean cost-free. Suppose you're admitted to a hospital as an inpatient in 2026. The Part A inpatient hospital deductible is $1,736. Here's an important difference between Part A and many health insurance deductibles. That $1,736 is not necessarily a once-a-year deductible. It applies to each benefit period. So, what exactly is a benefit period? A benefit period begins when you're admitted as an inpatient to a hospital or skilled nursing facility. It ends after you've gone 60 consecutive days without receiving inpatient hospital care or skilled care in a skilled nursing facility. That means you can potentially have more than one benefit period and pay more than one Part A deductible during the same calendar year. Let's make that practical. Suppose Robert is admitted to the hospital in February. He pays the $1,736 Part A deductible. If his inpatient hospital stay lasts 5 days, there is no additional daily hospital coinsurance for those first 60 days of the benefit period. He goes home. Now, suppose Robert is hospitalized again 30 days later. Because fewer than 60 days have passed, he's still within the same benefit period. He generally would not owe another Part A deductible simply because this is a second hospital admission. But imagine instead that Robert recovers, stays out of the hospital and skilled nursing facility for more than 60 consecutive days, and then is admitted again later in the year. That's a new benefit period, and he could owe another $1,736. Part A deductible. There is no limit to the number of benefit periods you can have in a year. Now let's look at a long hospital stay. After you've paid the Part A deductible, your hospital coinsurance is $0 per day for days 1 through 60. For days 61 through 90, you pay $434 per day in 2026. So, if you remained hospitalized for all 30 of those additional days, days 61 through 90 alone could mean $13,020 in coinsurance. After 90 days, another Medicare rule becomes important: lifetime reserve days. Medicare gives you 60 lifetime reserve days. For days 91 through 150 of a hospital stay, you can use those reserve days and pay $868 per day in 2026. But these aren't 60 new days every year. They're lifetime reserve days. Once you've used one, that day is gone from your lifetime total. And after those lifetime reserve days are exhausted, you may be responsible for all hospital costs beyond Medicare's covered days. Part A can also cover short-term care in a skilled nursing facility, or SNF, when Medicare's requirements are met. Generally, this includes a qualifying inpatient hospital stay of at least 3 consecutive days, followed by medically necessary skilled care in a Medicare-certified facility. And here's an important distinction. Time spent in the hospital under observation generally does not count toward that 3-day inpatient requirement. For a Medicare-covered skilled nursing facility, stay in 2026, you pay $0 per day for days 1 through 20 after the applicable Part A deductible has been satisfied. For days 21 through 100, you pay $217 per day. If you needed all 80 of those coinsurance days, days 21 through 100, that would total $17,360. After day 100, Medicare Part A generally pays nothing toward that skilled nursing facility stay. And this is where we need to distinguish skilled nursing care from long-term custodial care. Medicare Part A is not designed to pay indefinitely for someone to live in a nursing home because they need help with everyday activities, such as bathing, dressing, eating, or using the bathroom. We'll come back to that major coverage gap later in this video. So the key lesson with Part A is this: most retirees pay no monthly Part A premium, but that doesn't mean hospital care is free. You can face a $1,736 deductible for each benefit period, substantial daily coinsurance during a long hospital stay, and potentially significant costs for an extended skilled nursing facility stay. And that's only Part A. Next, we'll look at Medicare Part B, the coverage you're likely to use. Medicare Part B is the part of Original Medicare that most retirees interact with on a regular basis. It helps cover doctor visits, specialists, outpatient care, preventive services, diagnostic tests, durable medical equipment, ambulance services, mental health care, and many other medically necessary services. But understanding Part B requires more than remembering the familiar phrase, Medicare pays 80% and you pay 20%. Because that statement is often true, but it isn't the whole story. Let's start with what you pay just to have Part B. In 2026, the standard Medicare Part B premium is $202.90 per month. Most people pay the standard premium, although higher income beneficiaries can pay more because of something called the Income-Related Monthly Adjustment Amount, or IRMAA. And if you're already receiving Social Security benefits, your Part B premium is generally deducted directly from your monthly Social Security payment. Now comes the deductible. In 2026, the Part B deductible is $283. And this is very different from the Part A deductible we discussed earlier. Remember, the Part A hospital deductible applies to a benefit period, and you could potentially have more than one benefit period during the same year. Part B is simpler. The $283 Part B deductible is an annual deductible. You generally satisfy it once during the calendar year. The $283 deductible may sound surprisingly low, but don't let that number give you a false sense of security. For many beneficiaries, the larger financial exposure comes after the deductible has been met. That's because you may continue paying 20% of the Medicare-approved amount for many Part B services, and Original Medicare has no annual out-of-pocket maximum on that cost sharing. After that deductible has been met, Medicare begins paying its share of most Part B covered services. And this is where the 80-20 rule comes in. For many Part B services, Medicare generally pays 80% of the Medicare-approved amount, and you pay the remaining 20%. Notice the words I used, the Medicare-approved amount. That's important. The calculation isn't necessarily based on whatever amount appears on a doctor's original bill. Let's use an example. Suppose Maria sees a specialist for a Medicare-covered service. For simplicity, assume Maria has already satisfied her $283 Part B deductible for the year. And let's say the Medicare-approved amount for that service is $300. If the standard 80-20 coinsurance applies, Medicare pays 80%, $240. Maria pays 20%, $60. Now imagine the provider's regular charge for that service is $500. That does not automatically mean Maria pays 20% of $500. If the provider accepts Medicare assignment, the provider agrees to accept the Medicare-approved amount as full payment for the covered service. So, the Medicare-approved amount, not simply the provider's advertised or regular charge, becomes central to determining what Medicare and Maria pay. This brings us to an important phrase every Medicare beneficiary should recognize: accepts assignment. A doctor or other healthcare provider who accepts assignment agrees to accept the Medicare-approved amount as full payment for a Medicare-covered service. Medicare pays its share, and you are responsible for your deductible and coinsurance as applicable. But not every provider handles Medicare exactly the same way. Some providers participate in Medicare and routinely accept assignment. Some are non-participating providers. A non-participating provider may still accept Medicare patients, but may not accept assignment for every service. In many cases, these providers may charge more than the Medicare-approved amount. Federal rules generally limit that additional charge to no more than 15% above the Medicare-approved amount for services subject to what's called the limiting charge. That additional amount is often referred to as an excess charge. Let's make that distinction practical. Suppose the Medicare-approved amount for a covered physician service is $1,000. If your provider accepts assignment and the standard 80-20 structure applies, Medicare generally pays $800 and you pay $200, assuming your annual deductible has already been met. But with a non-participating provider who doesn't accept assignment for that service, your financial responsibility can be higher. And there is another category you should know about. Some doctors and practitioners formally opt out of Medicare. If you receive non-emergency care from an opt-out provider under a private contract, Medicare generally won't pay for those services, and you may be responsible for the amount you agreed to pay. So, before receiving expensive non-emergency care, particularly from a new specialist, it can be worth asking, do you accept Medicare? And do you accept Medicare assignment? Now let's look at another major source of confusion: provider networks. If you've had employer health insurance, or if you've looked at Medicare Advantage plans, you're probably familiar with the terms in-network and out-of-network. Original Medicare works differently. Original Medicare does not generally use an HMO or PPO style provider network. With Original Medicare, you can generally see any doctor or hospital anywhere in the United States that takes Medicare. That nationwide flexibility can be particularly valuable for retirees who travel frequently, spend part of the year in another state, or simply want broader access to specialists. But don't confuse no traditional network with every doctor must take Medicare. They don't. That's why checking whether a provider takes Medicare and whether the provider accepts assignment remains important. Now compare that briefly with Medicare Advantage. Medicare Advantage is the private plan alternative to receiving your Part A and Part B benefits through Original Medicare. And this is where terms such as HMO and PPO become especially important. With a Medicare Advantage HMO, you generally need to use doctors, hospitals, and other providers within the plan's network, except in situations such as emergency care, urgent care, or certain other exceptions. Depending on the plan, you may also need referrals or plan approval for certain services. A Medicare Advantage. PPO generally gives you more flexibility. You can typically receive covered services from out-of-network providers that meet the plan's requirements, but you will usually pay more when you go outside the network. So when someone says, "My doctor takes Medicare," that doesn't necessarily answer the Medicare Advantage question. The doctor might accept Original Medicare, but not participate in the network of your particular Medicare Advantage plan. Those are two different questions. We covered Medicare Advantage in more detail in another retirement briefing episode, so I don't want to turn this Part B discussion into another Medicare Advantage video. But understanding the distinction is essential. Original Medicare generally gives you broad access to providers that take Medicare. Medicare Advantage may use HMO or PPO networks with its own rules and costs. Now, what about prior authorization? This is another area where people sometimes oversimplify the difference. Prior authorization means approval may be required before Medicare, or a health plan covers certain services, procedures, or medical equipment. Medicare Advantage plans commonly use prior authorization for certain covered services. Original Medicare generally relies much less on this kind of plan-based approval system, but that does not mean prior authorization never exists under Original Medicare. Medicare has prior authorization requirements for certain services and items in particular circumstances. So, you should never assume that because you have Original Medicare, every recommended procedure automatically receives Medicare payment. You still need to make sure the service is Medicare covered, medically necessary under Medicare's rules when required, and provided under the applicable Medicare requirements. Now, let's return to that 20% coinsurance. 20% may not sound like much when we're talking about a $100 office service. 20% would be $20. But consider a more expensive Medicare-covered service. If the Medicare-approved amount were $1,000, your 20% share would be $200. At $5,000, 20% would be $1,000. At $10,000, 20% would be $2,000. And if you require several expensive Part B services during the same year, those amounts can accumulate. This leads to one of the most important financial facts about Original Medicare. There is no annual out-of-pocket maximum for your original Medicare Part A and Part B cost sharing. Think about what that means. You pay your Part B premium. You satisfy your annual Part B deductible. And then, for many covered services, you continue paying your applicable coinsurance. There isn't a point under Original Medicare alone where Medicare simply says, "You've spent enough this year. Your Part A and Part B cost sharing is now zero." That is one reason many Original Medicare beneficiaries consider supplemental coverage, such as Medigap. We'll come back to that later. But there's another important qualification. Not every Part B service costs you 20%. And that's where we'll continue next. Not every Medicare Part B service follows the standard 20% coinsurance rule. That's important because some Medicare-covered services can cost you nothing when Medicare's requirements are met. Preventive care is a good example. Part B covers a number of preventive services, including certain screenings, vaccines, and counseling services. For many qualifying preventive services, you pay nothing when the service meets Medicare's requirements and your provider accepts assignment. But there can be a catch. Suppose you schedule a preventive visit and during the appointment mention a new medical problem. Your doctor examines that problem, orders additional tests, or performs another service that isn't included in the preventive benefit. The preventive service may still cost you nothing, but those additional diagnostic or medical services can result in Part B deductible or coinsurance charges. So, a free preventive visit does not necessarily mean that everything done during that appointment is free. Outpatient hospital care is another area where costs can become more complicated. Suppose you have a procedure at a hospital without being formally admitted as an inpatient. Part B may cover the physician, outpatient hospital services, diagnostic tests, anesthesia, and other medically necessary care. But those services can generate different charges. You might have coinsurance for the physician and a separate copayment or coinsurance for the hospital outpatient service. And simply spending a night in a hospital does not necessarily mean you're an inpatient. Your status can affect which part of Medicare covers your care and what you may have to pay. Now let's put the Part B rules together with a practical example. Meet David. David has Original Medicare Part A and Part B. At the beginning of the year, he hasn't yet satisfied his $283 Part B deductible. David develops persistent shoulder pain. He sees his doctor, visits a specialist, receives diagnostic imaging, and eventually has a Medicare-covered outpatient procedure. His first covered Part B services help satisfy the $283 annual deductible. After that, many of his covered services are subject to the standard 20% coinsurance based on Medicare-approved amounts. For illustration, suppose David eventually receives $6,000 of services subject to that 20% coinsurance after his deductible has been met. His share would be approximately $1,200. That's in addition to his $283 deductible and the Part B premiums he pays throughout the year. Now, suppose David develops another medical problem later that year. He generally doesn't have to satisfy another Part B deductible. He has already met the annual deductible, but his 20% coinsurance doesn't stop. If he receives additional covered services subject to coinsurance, his out-of-pocket expenses can continue accumulating. And that brings us to one of the most important financial risks under Original Medicare. Original Medicare does not have an annual out-of-pocket maximum for your Part A and Part B cost sharing. There isn't a fixed dollar amount where Original Medicare says, "You've spent enough this year. We'll now pay 100% of all your covered Part A and Part B costs." That's one reason many people with original Medicare consider additional coverage such as Medicare supplement insurance, commonly called Medigap. Prescription drugs are another piece of the puzzle. Original Medicare Part A and Part B generally don't provide comprehensive coverage for the prescription medications you pick up at a pharmacy. That's where Medicare Part D typically comes into the picture. We'll deal with those additional coverage choices separately. For now, remember the essential Part B picture. You pay a monthly premium. You have one annual deductible, $283 in 2026. For many covered services after the deductible, you generally pay 20% of the Medicare-approved amount. Some qualifying preventive services can cost you nothing. Original Medicare generally gives you broad freedom to use providers throughout the United States that take Medicare. But there is no annual out-of-pocket maximum for your Part A and Part B cost sharing. And that leads directly to our next question. What doesn't Original Medicare cover? Routine dental care, routine vision care, hearing aids, most long-term custodial care, and several other expenses can remain largely your responsibility. Let's look at those gaps next. Now that we've looked closely at what Medicare Part A and Part B cover, let's look at the other side of the equation. What doesn't Original Medicare cover? This matters because some of the expenses Medicare leaves out can become significant as you get older. Let's start with dental care. Original Medicare generally doesn't cover routine dental services, such as cleanings, fillings, dentures, or dental implants. There are limited exceptions when certain dental services are directly connected to covered medical treatment. But for ordinary dental care, you should generally expect to need another source of coverage or pay the cost yourself. Next is routine vision care. Original Medicare generally doesn't cover routine eye exams for eyeglasses or contact lenses. Medicare does cover certain medically necessary eye services and screenings under specific circumstances, but routine vision care is different. The same issue applies to hearing care. Original Medicare generally doesn't cover hearing aids or exams specifically for fitting hearing aids. For someone who eventually needs hearing aids, that can become another significant out-of-pocket expense. But perhaps the biggest misunderstanding involves long-term care. Medicare is health insurance. It is not comprehensive long-term care insurance. As we discussed earlier, Medicare can cover qualifying short-term skilled nursing facility care. But that's very different from paying indefinitely for someone to live in a nursing home or receive ongoing help with everyday activities. If what you primarily need is custodial care, help with bathing, dressing, eating, or other activities of daily living, Original Medicare generally doesn't pay for that long-term care. And those costs can potentially become one of the largest financial risks a retiree or family faces. Prescription drugs are another important consideration. Part A and Part B cover certain medications in specific medical settings, but they don't provide comprehensive coverage for the prescriptions you routinely pick up at a pharmacy. That's why people choosing Original Medicare commonly consider separate Medicare Part D prescription drug coverage. International travel creates another potential gap. Original Medicare generally doesn't cover health care received outside the United States, except in limited circumstances. So, retirees who travel internationally shouldn't assume their Medicare card provides comprehensive medical coverage overseas. Now, put these gaps together. Imagine a retiree who needs regular dental work, prescription eyeglasses, hearing aids, several medications from a local pharmacy, and eventually assistance with everyday activities. Having Medicare Part A and Part B does not mean all of those expenses are covered. And remember, there are actually two different financial risks here. First, Medicare may cover a service, but you still have to pay your deductible, coinsurance, or other applicable cost sharing. Second, there are services. Original Medicare generally doesn't cover it all. Those are very different kinds of exposure. That's why your Medicare planning shouldn't end with the question, do I have Part A and Part B? A better question is, after Medicare pays what it's designed to pay, what expenses am I still responsible for? For some people, additional protection may include Part D prescription drug coverage and a Medicare supplement insurance policy, commonly called Medigap. Others choose Medicare Advantage, which may include prescription drug coverage and additional benefits, but also comes with its own provider networks, cost sharing, and plan rules. The important lesson is simple. Medicare Part A and Part B provide an enormously important foundation for healthcare in retirement. But they're a foundation, not a promise that every healthcare expense will be paid. Understanding what's missing is just as important as understanding what's covered. Next, we'll put everything together and look at what you should actually check before deciding whether your Medicare coverage is enough for you. We've covered a lot. We've seen what Medicare Part A covers, what Part B covers, what you may have to pay, and some important expenses original Medicare leaves uncovered. So let's finish with the practical question. What can you do about those gaps? If you choose original Medicare, think of Part A and Part B as the foundation. But many retirees add other coverage around that foundation. One important piece is Medicare Part D. Part D is prescription drug coverage offered through private insurance companies approved by Medicare. If you have original Medicare, you can generally purchase a separate Part D plan to help cover prescription medications you pick up at a pharmacy. Part D plans have their own premiums, formularies, pharmacies, and cost-sharing rules. So, Part D deserves its own detailed discussion. For now, remember one simple point. Part A plus Part B does not automatically give you comprehensive outpatient prescription drug coverage. Now let's talk about Medigap. Medigap is also called Medicare Supplement Insurance. It is private insurance designed to help pay some of the out-of-pocket costs that original Medicare leaves you responsible for, including certain deductibles, coinsurance, and co-payments. And here's where the terminology can become confusing. You may have heard people talk about Plan G. Plan G is not Medicare Part G. Medicare has Parts A, B, C, and D. Plan G is one of the standardized Medicare supplement, or Medigap, plans. Let's use Plan G as a practical example. Remember our Part B discussion. In 2026, you have a $283 annual Part B deductible. After that deductible, you generally pay 20% of the Medicare-approved amount for many Part B services. With standard Medigap Plan G, you generally remain responsible for that $283 Part B deductible. But after you've met it, Plan G can cover much of the Part A and Part B cost sharing that original Medicare would otherwise leave you to pay. For example, Plan G covers the Part A hospital deductible. It covers Part A hospital coinsurance according to the standardized Plan G benefits. It covers Part B coinsurance, and it covers Part B excess charges. So remember David from our Part B example? We showed how repeated 20% coinsurance could continue accumulating because original Medicare alone has no annual out-of-pocket maximum. A Medigap policy, such as Plan G, can dramatically change that exposure for Medicare-covered services. But there's an important warning. Medigap does not fill every gap we've discussed. Plan G doesn't turn routine dental care into a Medicare-covered benefit. It doesn't provide comprehensive routine vision coverage. It doesn't generally cover hearing aids. It doesn't provide comprehensive long-term custodial care. And Medigap policies sold today don't include prescription drug coverage. That's why someone choosing Original Medicare might have four pieces: Part A, Part B, a separate Part D prescription drug plan, and a Medigap policy such as Plan G. Each piece has a different job. There is also a high-deductible version of Plan G. In 2026, its deductible is $2,950. With that version, you pay Medicare-covered costs up to the applicable high deductible before the Medigap policy begins paying according to its benefits. The premium can be different from standard Plan G, so high-deductible Plan G should be evaluated separately rather than assuming one version is automatically better. So that's one way retirees can build their coverage around Original Medicare. But there is another path: Medicare Advantage. Let's compare the two approaches and then finish with 5 questions you should ask before choosing your Medicare coverage. Now let's look at the other major path: Medicare Advantage, also called Medicare Part C. Instead of receiving your Part A and Part B benefits directly through Original Medicare, Medicare Advantage plans are offered by private insurance companies approved by Medicare. You still have Medicare, and you must continue paying your Part B premium. But the Medicare Advantage plan becomes the primary way you receive your Part A and Part B covered services. Most Medicare Advantage plans include prescription drug coverage, and many offer additional benefits such as certain dental, vision, or hearing coverage. That can make the Medicare Advantage approach appear simpler than combining Original Medicare with separate Part D and Medigap coverage. But simplicity isn't the only consideration. As we discussed earlier, Medicare Advantage plans can use provider networks. An HMO may require you to receive most non-emergency care from providers within the plan's network. A PPO generally offers more flexibility to use out-of-network providers, but you may pay more when you do. Plans may also have prior authorization requirements and their own co-payments, co-insurance, deductibles, and other coverage rules. One important difference is that Medicare Advantage plans have an annual limit on your out-of-pocket costs for covered Part A and Part B services. Original Medicare by itself does not. But remember what an out-of-pocket maximum means. It does not mean all of your healthcare expenses are capped. Your premiums, prescription drug costs, and services that aren't covered by the plan can be treated differently and may not count toward that medical out-of-pocket limit. So, neither Original Medicare nor Medicare Advantage should be chosen based on one attractive number. Before you make your decision, ask 5 questions. First, what will I pay every month? Include your Part B premium, and then consider premiums for Part D, Medigap, or a Medicare Advantage plan, depending on the path you choose. Second, what could I pay when I actually need health care? Look beyond premiums. Understand deductibles, co-payments, co-insurance, hospital costs, and your potential exposure during a year when you need significant medical care. Third, can I use the doctors, specialists, and hospitals I want? With Original Medicare, ask whether your providers take Medicare and whether they accept assignment. With Medicare Advantage, check the plan's provider network and understand the rules for receiving care outside that network. Fourth, how are my prescription drugs covered? Don't simply ask whether a plan includes drug coverage. Check whether your medications are on the plan's formulary, what tier they're on, which pharmacies you can use, and what you could actually pay. And fifth, what important expenses are still not covered? Think about dental care, vision, hearing aids, international travel, and especially the possibility of long-term custodial care. Those expenses don't disappear simply because you have a Medicare card. And your answer today may not remain your answer forever. Your medications can change, your doctors can change, your health can change. Plan premiums, networks, formularies, and benefits can change. That's why Medicare coverage deserves to be reviewed periodically rather than treated as a decision you make once and never examine again. If there's one idea to remember from this entire discussion, it's this. Having Medicare and having all of your healthcare costs covered are not the same thing. Part A provides important hospital coverage. Part B provides essential medical and outpatient coverage. Part D can help with prescription drugs. Medigap can help fill many of the cost-sharing gaps left by original Medicare. And Medicare Advantage provides another way to receive your Medicare benefits, with a different combination of costs, benefits, networks, and rules. The right choice depends on your healthcare needs, your finances, your medications, your preferred providers, and how much flexibility you want. So don't ask only, which Medicare option has the lowest premium? Ask, what will I pay when I'm healthy? And what could I pay when I'm not? What healthcare choices will I have? And which financial risks am I comfortable keeping? And which ones do I want insurance to cover? Those are the questions that turn Medicare from a collection of confusing parts, plans, premiums, and percentages into a retirement healthcare strategy you can actually understand. Because the goal isn't simply to enroll in Medicare, it's to understand what Medicare pays, what Medicare leaves you paying, and how those costs fit into the retirement you've worked so hard to build. Before making a Medicare coverage decision, consider verifying the details at Medicare.gov or speaking with your local State Health Insurance Assistance Program, known as SHIP. SHIP provides free personalized Medicare counseling and isn't connected to an insurance company or health plan. And if this guide helped you better understand Medicare, subscribe to the Retirement Briefing. You can also watch our Medicare Advantage guide next for a closer look at how those alternative compares with original Medicare. Your retirement, our focus.